Good morning, all dignitaries. I am Dr. Hussainur Rehman, Assistant Professor in Department of Cardiothoracic and Vascular Surgery. It is indeed an honor for me to present a clinical combined rounds for my department. Before I start, I want to take few minutes to introduce everybody to my department. So our department has been established in year 2012, and since 2019, the MCI has given us permission to admit one resident per year for MCH training. And this year we have one resident under the guidance of our able faculty. She has been trained. The departmental structure is as follows. Dr. Chisti sir, he is the professor and HOD of our department. Then Dr. Ajay Meena sir, he is the unit head and associate professor of our department. Then myself as an assistant professor. And the pediatric unit is headed by Kausal sir. He is the director and head of the department of the pediatric unit. We have 3 dedicated modular OTs, which has been used in the daily basis for all our essential surgical works. We have a dedicated ICU of 16 bed, which is manned by very highly skilled and trained nursing staffs and under the supervision of cardiac surgeons as well as cardiac anesthesia team. As we all know that as a super specialty branch doing all sorts of cardiothoracic procedures, we need few high-end specialized equipments. We have a range of equipments that we use on our daily basis. For example, we have 2 IABP units. This is a intra-aortic balloon pulsation unit which we use for hemodynamically unstable patients. Then we have a cardiopulmonary bypass machine. This is a machine which we use for all kinds of open heart and as well as other thoracic procedure and vascular procedures also. We have a transthoracic as well as a transesophageal echocardiography machine which we use on a regular basis to monitor the vital parameters as well as operative and post-operative management of the patient. We have a cell saver machine. This is a high-end machine which we use as a blood conservation strategy so that we can minimize the transfusions in the patients. We have a temperature control machine as we have to maintain a very precise temperature during all kind of procedures, so this machine helps us. As I have earlier said that we have a dedicated nursing team. The nursing team continuously goes on different educational training as well as they have received multiple awards for their good work. As our department has been awarded multiple awards during the period, as well as we have conducted multiple workshops and training programs under the supervision of our HOD and team. We have conducted various workshops in which other departments have also been included. As per the statistics, in the last 1 year, we had OPD of around 1400 patients, out of which 730 patients were converted as indoor patients, and we have conducted 617 surgical procedures. We have conducted 77 emergency procedures during that period, and our total mortality during that period is 10, which is one of the exceptional results. In our department, we conduct a spectrum of cases. The most common cases that we deal on regular basis are coronary artery bypass surgeries, all kind of valvular lesions we deal with. We deal with single valve repair as well as replacement, double valve, triple valve repair and replacements. We also do combined procedure in a single setting like bypass surgeries with valve procedures with peripheral vascular procedures in a single setting. We are well equipped and we are handling aortic procedures on routine basis where we deal with aortic aneurysm and aortic dissections, both thoracic as well as abdominal. We are also doing redo cardiac surgeries on regular basis. Redo cardiac surgeries are the procedures that which has been dealt once, but due to some complication or in future some other diseases may have occurred, so we have to reoperate those patients. Then we are also conducting thoracic procedures, the lungs, which include procedure of lungs like pneumonectomy, lobectomy, and decortications. We have also dealt with thoracic tumors. Vascular procedures we are doing on the regular basis, in which we deal with aorta as well as the peripheral vessels. Congenital heart surgeries are being dealt with, and other miscellaneous surgeries. We had a very good aortic program in which we have constantly improved, and in last 2-3 years we have constantly improved in aortic aneurysmal surgeries. So now I want to invite Dr. Vini. She will be continuing with the clinical presentation today. Thank you.
A resident from the Department of CTVS. I will be taking the case forward. Speaking of the particulars, the patient was 61-year-old female. She is a housewife, resident of Nagaur, Rajasthan. She presented in our OPD with a chief complaint of shortness of breath for past 3 days. She was apparently asymptomatic 3 days ago, and she walked on into the OPD with a complaint of sudden onset of dyspnea, which was progressively worsening and was even present at rest when she presented. And this symptom was associated with palpitations. So it came down to the class of NYHA 4. She has no history of chest pain, fever, vomiting, no history of sore throat, cold or cough, no history of joint pain, rashes, no history of transient loss of consciousness. When we talk of the past history, she underwent a mitral valve replacement with using a 27 mm St. Jude valve, mechanical valve, along with tricuspid valve repair with de Vega's technique on 18th of March 2023. She is a known case of hypertension on medication for past 3 years, no other significant history and no other comorbidities. Drug history, she was on following medication for post this mitral valve replacement. Tablet aspirin 75 mg once a day, tablet Telma for hypertension 20 mg once a day, and tablet warfarin with the dose adjustment according to INR, although she was not compliant to the tablet INR monitoring. Personal history, she is vegetarian by diet, sleep and appetite are normal with normal bowel and bladder habits, no other addictive history, and no allergic history. Obstetric and gynecologist history, she is a gravida 1 with no live births, and she attained menopause at the age of 45 years. She had no history of any cardiac or respiratory disease in her family, and she belonged to low socioeconomic group. Then we move forward to the general physical examination. Patient was examined in adequate light and exposure with informed consent. She was conscious and oriented to time, place and person. The stats: height 160 cm, weight 52 kg, equivalent to BMI of 20.3. Her heart rate was 110 beats per minute. Pulse was irregular with low volume over right radial artery. All the peripheral pulses are palpable. Blood pressure was 100 by 60 mm of Hg on right upper arm in supine position. Jugular venous pressure was 6 centimeters of H2O. Respiratory rate was 34 per minute, and it was abdominothoracic type of respiration. Saturation was 92% on room air. Temperature 36.5 degrees centigrade, axillary. There was no pallor, cyanosis, icterus, clubbing, pulmonary edema, peripheral edema or peripheral lymphadenopathy. Moving forward to systemic examination, if we examine the cardiovascular system, on inspection, chest is symmetrical. There was no discoloration of distended veins. A median sternotomy scar was present. Palpation, normal cardiac apex, no tenderness. On percussion, there was no cardiomegaly. Heart borders were in the limit. On auscultation, there was a diastolic murmur present with the valve click, mechanical valve click should have been there, which was absent. On respiratory system examination, on inspection, chest is symmetrical, abdominothoracic pattern of breathing with a rate of 34 per minute, no tracheal division, no visible lymphadenopathy. On palpation, trachea is central with symmetrical chest expansion, no tenderness. Percussion were normal. On auscultation, there were bilateral basal crepitations. Gastrointestinal per abdominal inspection, scaphoid, central umbilicus, no scar or engorged veins, palpation soft and non-tender, abdomen, no organomegaly, no palpable mass or lump. On auscultation, there were normal bowel sounds. Neuromuscular examination was completely normal, conscious oriented, no neurological deficit, normal sensory and motor functions. So the case summary is a 61-year-old female having a complaint of 3 days of dyspnea, which was sudden in onset and progressively worsening, leading to NYHA class 4, landing into NYHA class 4, and with tachypnea, irregular pulse, saturation of 92%, with a median sternotomy scar, bilateral basal crepitations, diastolic murmur, and there was no wall click heard. So according to the history and this examination, we can make probable causes as cardiac or non-cardiac causes. Cardiac causes can be an acute MI, or this prosthetic valve must have got stuck. When we talk of the non-cardiac causes, it can be pneumothorax, pneumonia, ARDS, or pulmonary embolism. We will rule out these causes with further investigations, but here we can say that acute MI is...
Is it not possible to include dissecting aneurysm, aortic aneurysm?
Yes, sir, it can.
You should put it in cardiac causes, cardiovascular causes.
Yes, sir. From the chest pain, but
yeah, that I agree, but the patient is having abdominothoracic breathing.
yes,
That means something is there in the abdomen. Otherwise, usual breathing is the abdominal breathing. Here the patient is having thoracic breathing predominantly. Am I right? 34
yes, sir, 34 per minute.
respiratory.
Yes, sir.
You mentioned it is abdominothoracic.
Yes, sir.
That means thoracic is dominant. Kindly explain.
So respiratory distress is there, probably.
Respiratory distress में फिर abdominal breathing ज़्यादा dominant होती है. She is not pregnant. She is menopausal lady.
Yes, sir.
There is no mass also. So why she is having thoracic breathing more than predominantly part of thoracic breathing than?
Sir, probably this is more due to respiratory distress only.
Chalo. I think.
And the large majority of patients, the predominant symptom is severe chest pains, disabling, like the maximum pain. So it's very unlikely. Another thing, she has put number one as the aneurysm has a different presentation, sir. So another point I want to make is acute MI should be second. The first most likely probability is stuck valve. 80% of acute myocardial infarction is painful. Just 20-25% are painless, particularly in diabetic patients. So that first should come second, and second should come first.
It's also important to know in which area the diastolic murmur was present. Isn't it important?
Auscultation point.
Mitral area था, aortic area था.
Mitral area.
एक बेटा इनमें DVT भी थोड़ा देख लेना चाहिए. फीमेल पेशेंट है, ओल्ड पेशेंट है. आपने लिखा भी है कॉज पल्मोनरी एम्बोलिज्म, बट दैट शुड आल्सो बी इन द बैक ऑफ माइंड.
Yes, sir. So we went for the investigations. These are not the initial investigations though, but initial investigation would have been 2D echocardiography, but we just conducted these investigations to further study the case. So blood investigations, CBC was hemoglobin, CBC hemoglobin was 12.2, counts were 9,600, with DLC 72% of neutrophils, platelet 2.6 lakhs, and when we see this renal function test, creatinine was slightly raised of 1.3.
Are we doing BNP, brain nutri? Why? That is necessary to rule out, especially in the case of dyspnea. I think it's very important test, sir.
Important investigation. But someone who is in dire straits, like this patient, do we have to have a very focused investigation pattern so that we can get to the diagnosis as quickly as possible and institute life-saving measures? NT-proBNP helps us assess cardiac failure, and it's an expensive test, relatively expensive test, and it takes time to get it. There is a point of care test, yes. Yeah, there's a point of care test, but in this particular case, it wouldn't be very crucial.
Her INR was 1.25, which we will study later. Like the range of INR should have been maintained because she has undergone this prosthetic mitral valve replacement. So the particular range of INR should have been maintained. So according to that, the INR is on lower side. It's 1.25. Yes, sir. It's inadequate. Yes, sir. On ECG, we can see the rate of 110 per minute. Atrial fibrillation is there. QRS axis appears normal. There is left ventricular hypertrophy with no ST elevation. X-rays, we can see the sternal wires are visible. There is increased bronchovascular markings, and we can see the prosthetic mitral valve, which has been pointed out. 2D echocardiography is the main diagnosis. It is the initial diagnosis which is usually advised because it allows a real-time visualization of the mechanical valve functioning, any intracardiac mass or clot or vegetation, and to rule out the pulmonary embolism. Now I would invite Dr. Jatin Garg to speak on the echocardiography and fluoroscopy findings.
Thank you, Dr. Vini. Good morning, sir. So, on the echocardiography, myself, Dr. Jatin from Cardiology Department under Dr. Rajeev Sharma, sir. So, on the, as Dr. Vini told, the initial and most easily available non-invasive test is 2D echocardiography. In this, we have to assess the orifice area, the mean gradient and PG gradient, ejection velocity, and ejection time. But we focus morely on the more reliable parameters of PG and NG. Mechanical heart valve at mitral position, P gradient was 42 and mean gradient was 27 with no valvular or paravalvular leak. It's suggestive of the gradient more than 10 is suggestive of obstruction. So in this patient, the gradient was 42 and 27, which was suggestive of stuck mitral valve. Along with it, there was mild AR, moderate to severe TR, moderate pulmonary hypertension. There was no intracardiac mass, clot or vegetation. Ejection fraction was pretty normal, 50, and mild LV dilatation was there. All the cardiac chambers were normal. The echocardiography, this is just a theory part to explain our finding. Echocardiographic criteria for prosthetic mitral mechanical valves in severe obstruction, the criteria are for aortic valve, effective orifice area of prosthesis less than 0.8 cm and mean gradient around 35 mm. And for mitral valve, the effective orifice area prosthesis less than 1 cm square and the mean gradient more than 10. As described, the findings we focus more upon is the effective orifice area and the mean gradient. Now coming to the role of the fluoroscopy, mechanical valves are radio opaque as shown in the previous slide. So the leaflets are clearly visible on fluoroscopy. What we assess in the fluoroscopy investigation is it helps to us to evaluate the leaflet disc motility, opening angle, closing angle, symmetry of the movement, and the speed of the excursion. Now in this video you can see the mechanical valve. In this video, in the fluoroscopy, you can see the one leaflet of the valve is stuck, is not moving. Now I invite Dr. Vini again back to the podium to explain, to take it further.
So we have come to the diagnosis as such from the echocardiographic findings. So it is a stuck prosthetic mitral valve, and we can rule out the other causes by the investigations and everything which we have investigations and the history which we have seen. So X-ray findings were not suggestive of the other causes, and the history was not suggestive of the acute MI. So we are left with one probable cause here, that is a struck mitral valve.
It's a confirmed cause now,
Yes.
not a probable cause.
So the final diagnosis is struck prosthetic mitral. Prosthetic mitral valve can be due to various causes. So mostly in this case, because the most common cause of struck valve is a thrombus, and when we talk of mitral valve, it is mostly a thrombus. These the last 3 points, the prosthetic valve malposition, mechanical failure of the valve, and suture material tissue entrapment, they are usually acute causes of this mechanical valve dysfunction. Pannis formation is the fibrous band formation over the valve, which is more common in aortic valve than mitral valve. It is basically due to the thrush moment of the in a high pressure area. So that causes a fibrous band formation in a centripetal part of the valve.
I think she has got some pictures which she will show
Yes,
later
sir.
on.
So the most probable cause of struck valve is a thrombus here. So we move forward to the management of this condition. We have two options here. First, we can go for a trial of thrombolysis. This will actually help us to in between to to make the patient stable if you even want to go for a surgery, and it can also lead in complete resolvement of the thrombus. So trial of thrombolysis has been opted first, and it has been reported the mortality rate of this thrombolysis is 7%. The AHA guidelines mention that when we have a thrombus of less than 0.8 centimeter square and the patient is landing in class NYH 1 and 2, we should go for thrombolysis. Other than that, if it is more than 0.9 centimeter square, then we should opt for redo surgery. Although it has few lesser risk of the risk of bleeding and the risk of redo surgery have to be assessed. The risk here in this thrombolysis is risk of thromboembolism, which is basically less than 2% according to the AHA paper which was published in 2021, and the major bleeding risk was also less than 2%.
I'll just put one sentence here. The reason we chose trial thrombolysis in this patient, the major reason is that it's likely to be a very short, its history is very short, only 3 days, so the likelihood of having a pure thrombus is very high. That's why we chose thrombolysis as the first choice. Even though her NYHA class was very high, she was in distress, she was in class 4, and likely the thrombus burden was high, but we still chose thrombolysis because, why? Because the history is very short and likelihood of it being a pure thrombus was very high.
The success rate which have been reported is 75%, but when it is done echocardiography guided, then the success rate is reported to be 90%. The surgical management is when we can do the redo surgery, redo mitral valve replacement. It is first choice. It is an indication for this redo surgery is if there is failure of this thrombolysis, and it is a first choice in case of stroke or there is a recent surgery or an active bleeding. The mortality rate of redo surgery is 10 to 15%, and again the AHA paper says the classification that more than 0.9 centimeter square of thrombus should be opted for redo MVR. The risk of this surgery is sternotomy injury, which is basically to the vital structures behind the aorta and the right ventricle, and the risk of bleeding because patient was on anticoagulation, and complications which are present usually after CPB, cardiopulmonary bypass. Now I will invite Dr. Shreya to take the case forward from Department of Anaesthesia.
Good morning, everyone. Myself, Dr. Shreya Ahuja from the Department of General Anaesthesia. And as the patient presented with dyspnea and hypoxemia, so and the trial for thrombolysis was a decision for going for the trial of thrombolysis was made. So we received the patient in CTVS ICU, and we maintained the patient in a propped up position. We started patient on oxygen therapy at the level liters per minute, and diuretics were started. A central venous axis and a radial axis were taken. Foley's catheter was placed, and we started the patient on injection streptokinase, 2.5 lakh international unit IV over first 30 minutes, followed by 1 lakh international units over the next 24 hours. After that, a repeat echocardiography was done, but the gradients were still high. They were 21 and 13. So a decision was to repeat fluoroscopy was made, and the repeat fluoroscopy still showed one leaflet was stuck. So now we were left with a redo surgery, and a redo mitral valve replacement was planned for the next after the 5 days. During these 5 days, we pre-optimized the patient. We started the patient, we continued the diuretics, and anticoagulation was maintained by injection heparin. Adequate blood products were arranged preoperatively, and intraoperative sedation and hemodynamics were managed by a transesophageal echocardiography guidance. Intraoperatively, patient was induced and maintenance of anesthesia was done using routine protocols. Injection tranexamic acid 1 gram was given, and monitoring was done as per ASA guidelines. Intraoperatively, hemodynamics were managed using fluids, inotropes, dopamine, NTG, and noradrenaline were used and were titrated according to the blood pressures. Intraoperative trans-echocardiography was done, and this was the TEE of the patient intraoperatively, and it helps us in visualizing valvular function and and give us anatomical assistance. And after the surgery was done, it helped us in showing if there is any residual air present after the surgery, and it also assisted us in taking the patient off CPB. And we could monitor the live response to our vasoactive agents as well. Thank you. Now I would like to invite Dr. Vini ma'am back to take us further with the surgical management.
So we will talk about the surgery steps in brief. For redo mitral valve replacement, the position of the patient should be supine, painted and draped with the chest and bilateral femoral areas exposed in case for femoral cannulation, to go on bypass through femoral cannulation. And right femoral area was exposed for the need of this emergency CPB.
Is it routine to open both areas?
Keeping it ready is on the safer side, and also we will dissect the femoral area before and keep it no sir, not the both areas. We will loop the femoral artery and the femoral vein in case of need of emergency CPB.
In case there's an injury to the heart,
Yes.
which is sometimes happens in redo surgery because the heart is stuck to the back of the sternum. So we keep the femoral vessels exposed so that in case of a problem, we can start cardiopulmonary bypass with the groin cannulation. Sometimes when we assess that the risk of injury to the heart during this sternotomy is high, then we cannulate the femoral artery and vein preemptively before we start opening the sternum. In case there's a problem, we can just start the bypass. Go on.
In case of redo procedure, we have to be careful about the sternotomy. The saw which is used is called the oscillating saw. For this, first prerequisite is we have to lift the sternum up so as to maximize the prevention of bleeding beneath. And for initially we will cut the anterior table of the sternum first. Here we are separating the anterior table. After which we will keep a saw at an angle and move from cranial end to the caudal end, and just cutting all the wires and just taking them out one by one. So the two structures which can be cause bleeding here, major structures which are aorta and the right ventricle, they can lead to a catastrophic bleeding. So we are here removing the wires one by one. After this, we will go for aortoatrial cannulation for and after systemic heparinization. Initiation of cardiopulmonary bypass and cardioplegia is given to arrest the heart.
You didn't show the full video. Anyway, that was the crucial part you didn't show of the reduced sternotomy, which is a real challenge for most people. So it's very crucial that it's done safely. If you injure the aorta or the heart, aorta, the blood volume of 5 liters will be on the floor in 1 minute,
Yes, sir.
and you won't be able to do much. So the way we open the sternum, you have cut that. That was a very important video to show, which you have dismissed. Anyway, doesn't matter. Keep going.
Here the right, after this the right atrium was opened and through interatrial septum, left atrium was approached. On inspection here we can see, we'll be able to see now a thrombus on one leaflet of mechanical mitral valve along with minimal pannus all around. This is the
black thing we are seeing
is the leaflets, and this is the thrombus.
This is the other leaflet covered with thrombus.
This leaflet is moving.
This is unstuck. And you can see the lower part is completely covered with thrombus. There was no way you could medically open that.
There was no clot in the LA and the left atrial appendage. After this, the valve was explanted by removing all the sutures around. In the first video, we are separating the posterior annulus of the valve, and in the second video, you can see an explanted valve. Annular sutures were then taken all around, and the valve was sized using sizers and tied. The sutures, while taking the sutures over the valve, we have to ensure that they do not entangle. For this purpose, we are using a suture organizer, and we are using alternate colors of sutures for easy management. And these sutures are placed over the valve evenly and dividing into the 3 parts. And then the valve is seated down, and in each suture is tied over it, secured, and then cut. After this, the atrium was closed. Rate and rhythm was achieved through pacing wires placed on right atrium and the right ventricle. Then we weaned off from this cardiopulmonary bypass. Decannulation was done. Heparin was reversed with protamen, and sternum was closed back using stainless steel wires. This is a post-operative TE. We can compare it with the pre-operative TE, where in this second video you can see both the leaflets are moving in. And initially this leaflet was not moving. Now we will move forward to post-operative management of this patient. After surgery completion, patient was shifted to ICU on inotropic support. Patient had this developed this atrial fibrillation post-operatively on POD2, for which she was medically managed and was discharged satisfactorily on the POD post-operative day 8. Transthoracic echocardiography was repeated before discharge, and the mitral valve gradient came down to 6, mean gradient of 6. She presented in follow-up twice, and she is doing well, maintaining an INR range between 2.5 to 3, which is an ideal range for this mitral valve. And she is currently on tablet VORF, ranging between 8 to 9, which is again titrated according to the INR. Other medications which she is on is aspirin and Lasix and digoxin. Move forward to the review of literature. If you see a 5 by
till the next prescription. It's not for 5 days, till next prescription.
In a redo operation, can we use a bioprosthetic valve, or we should
Yes,
go
sir.
for a mechanical
No, no,
valve?
sir, we can
Since
use
the
a-
patient has a history of thrombus there.
Yes,
Yeah,
sir.
it's a very good, excellent point. Ideally speaking, someone who is non-compliant and has a mechanical valve and has thrombosed it, the ideal choice is a tissue valve.
Bioprosthetic.
But the problem is economics. People cannot afford tissue valves, more expensive. And the cheaper tissue valves are not much better, not more very reliable, because long term the results are not good. They degenerate very fast. Good tissue valve is about 2.5 to 3 lakh. So people are not able to afford.
I saw the factory of the tissue valve by Professor Cherian Joseph in near at the border of Kerala and Andhra Pradesh.
Gee.
He came here for oration also, Dr.
Yeah, I know
Sunawala.
Dr. Cherin very well.
Yes, yes. And he showed me the big walls formation and big project was there. So, what is the condition at the moment? I
So
saw
I
it
don't
almost
think
10
that-
years back.
I don't think any Indian tissue valve is taken off except Merrill. Merrill is a company that makes mechanical as well as tissue valves. So I'll reserve my comments on Merrill and their valve. But हमारे पास जो अभी ले दे के options है दो. Epic है. Epic is a big valve, which is relatively cheaper. Not cheap enough for our patients to afford, but it's relatively cheaper. I think it's 1.5 lakh. And long-term results are not good with this valve, in my experience. But
Because we pursued that matter with the Prime Minister also,
Ji,
with the help of Dr. Sunawala, late Dr. Sunawala,
yeah.
to push
So-
that project.
So absolutely, it's
14
not
or
it's
15.
something impossible to do, but obviously it takes a lot of work. I think it is very capital intensive, and we have to have good researchers who are hardworking and dedicated. And there are regulations which are very strict about heart valves, which we have to meet. They are very expensive to conduct the trials and then finding it the approval. So for this particular patient, Magna Ease from Edwards would be an ideal valve. It would give her at least 10 years. She's already 60. 71 तक तो आराम से जी सकती थी. लेकिन the only reason we used a mechanical valve is because she cannot afford the extra. She has to pay over and above what the government pays. And unfortunately, previously he had a St. Jude mechanical valve, which is a very good valve, I think the best in the market, maybe with the exception of OnX. But again, she's not able to give the difference between the Sarkari valve and the St. Jude valve. So she gets the Sarkari valve. Okay.
Just a small history about the mechanical valves. The first valves which were used were ball and cage type. You can see in the first photograph here. And the second valves which evolved was tilt-in disc, which are having a single leaflet. And the St. Jude bileaflet valve was invented in 1977, which is having similar structure and no much changes from then. And the recent valve which has been used is Onyx valve, which was invented in 1996. The incidence of this prosthetic mechanical valve thrombosis for a mitral valve, according to AHA 2021, is 0.1 to 5.7%. It's a big range because it depends on the different type of valve companies and the types of valves. Mitral valve thrombosis is more common than aortic valve thrombosis. These are the commonly used brands. If we compare the incidence in thrombus formation in these particular valves, we can see the least incidence is in Onyx valve. And there are specific location of thrombus formation which has been found for these different types of valves. And specifically, all these valves are made up of different material. They have slight changes in the materials which has been used. For the TTK Chitra, it has a titanium frame, and for the Merrill, it has got a graphite core over which a silicon alloyed pyrolytic carbon has been used. And the St. Jude is purely pyrolytic carbon. And onyx, there is pyrolytic carbon on graphite core, but it is not silicon alloyed. And this Carbomedics has a tungsten graphite core. TTK Chitra and Merrill are Indian-based companies, and rest three are US-based companies. So the causes of thrombus formation in general over any prosthetic mechanical valve is inadequate anticoagulation being the first reason, subtherapeutic INR, non-compliant patient. Prosthesis related, the valve related causes can be thrombogenic surface and structural stasis, which is basically the hinge part of the valve which is more prone to the thrombus formation. If you talk about hemodynamic factors, low pressure and low flow states can be responsible. Atrial fibrillation, where there is loss of atrial contraction, which will lead to LA thrombus basically, but can also be a precursor. Hypercoagulable states like pregnancy, malignancy, and sepsis can also lead to thrombus formation. So to prevent this thrombus formation and thromboembolism in future, we have to keep these patients which have undergone this mitral valve replacement on anticoagulation therapy. This anticoagulation therapy can be maintained, INR can be maintained with the use of vitamin K antagonist, more commonly use of warfarin and acetocomerol, trade name is acetrom. Aspirin has to be given additionally, which can range 75 to 100 milligram. Duration of this anticoagulation therapy for mechanical valves is lifelong, and for prosthetic valves is usually they endothelialize between 6 months, so we can stop after that.
The tissue valve is 3 to 6 months, prosthetic is lifelong.
Yes, sir.
Reverse.
Yes, sir. In case this therapeutic INR is not achieved through these drugs, we can bridge in heparin, injectable heparin, along with this oral anticoagulation. The certain foods have to be avoided which are rich in vitamin K, like green leafy vegetables, cabbage, turmeric supplements, green tea, because they will interact with the function of the vitamin K antagonist. There are certain drug interactions with these drugs. They will increase the INR. So NSAIDs, antibiotics, antifungals, amiodarone, they should be used cautiously when we are given warfarin to such patients.
What's the recent role of NOACs in tissue, this wall replacement? Still not used? Oral anticoagulation.
Yeah, she didn't get the question, so I'll respond. NOACs are not to be used in presence of a prosthesis. When there's a prosthesis, the reason likely is that there is the thrombosis still occurs. The degree of number of valves that get stuck, the valves that get thrombosed, or prostheses that get thrombosed, is higher than with warfarin. So still warfarin is the only choice we have, although it's inconvenient for the patient for the reason that it has to be monitored with regular INR estimation, which is not required for NOACs. I hope in future we get something to replace warfarin, which has a stable response with the body and does not need regular monitoring. The part of the reason that some of these people get stuck valves is, I think the main reason is because they're not able to get the INRs done regularly, and it's quite expensive for them to travel all the way from their places, have a doctor's consultation, get an INR done, and go back home. So many people just forget about it. They get the valve replacement, they don't get it done. Yesterday I got one patient, she had not done an INR for the last 5 years. Occasionally she was getting INR done, but she was not showing anybody the result. I don't understand what logic works in their mind. Okay.
So there is a proper AHA guideline given for INR maintenance, INR range. For mitral valve, it should be between 2.5 to 3.5. And for a mitral valve with risk factors there, like patient having atrial fibrillation, previous history of thromboembolism, any hypercoagulable state, where you have to maintain an INR, slightly higher INR of 3.5 to 4. For aortic valve, it is slightly less, it's 2 to 3. And with risk factors is 2.5 to 3.5. Benefit of anticoagulation therapy must be weighed against the risk of bleeding. So the take-home message for this is prosthetic wall thrombosis is a life-threatening emergency and requires rapid diagnosis and timely intervention. Rapid diagnosis with transthoracic and transesophageal echo and fluoroscopy for leaflet motion is crucial. Long-term success of this prosthetic wall depends on INR compliance, adequate anticoagulation, patient education, and regular follow-up.